Mechanical stressors, the most undertaught, misunderstood, or not understood aspect of rehab, and the main thing that keeps a lot of people in a lot of pain that clinicians and patients don't understand.
When I didn't have an understanding of mechanical stressors, the spiel that I would use to explain people's injuries to them didn't really make sense. So if somebody comes in for back pain, for instance, I would tell them, oh, well, it's, you've done this thing so many times in this way, talking about the movement pattern. Let's say it's deadlifting, right? But they didn't throw out their back deadlifting. They threw out their back picking up a pillow. And I would just equate it to it's the number of times that you've done it in the bad way. It doesn't explain why it got irritated, but it blames the movement pattern itself and it misses a lot of context. So let's dive into that.
What are mechanical stressors? Well, mechanical stressors are the forces within the body that the patient is sensitive to that are keeping them in pain and keeping them sensitized, keeping their nervous system irritated, okay? So they break down individually into load, position, neural tension, right? Load sensitivity, positional sensitivity, neural tension sensitivity, and static position intolerance or static position sensitivity. So what is a load sensitivity? Well, a load sensitivity is a sensitivity, how many times can I say that word? To the increased compression forces on the spine through internal loading, never mind external loading, right? So, for example, when you're standing, you're at 100% of your body weight on your lumbar spine. When you're laying on your back, you're at 25%. When you spit your toothpaste out, it's 150%. When you're sitting like humans sit, it goes up to 185% with no extra external loading at all. So understanding how that plays into somebody's day is very, very important, okay? If they have pain at work, and they have a desk job, is it load sensitivity from the increased loading, or is it position sensitivity from them being in a flexed position all day? You have to be able to parse those out, right? So position, most people are familiar with that. Is there a flexion? Are they extension sensitive? But they also miss, are they side bending sensitive? Are they rotationally sensitive? Are they sensitive only when there's a combination of positions, like when they flex and side bend to grab the railing as they're going down the stairs, or when they side bend and rotate to grab their seatbelt? Are they sensitive to a combination, right? And then you have neural tension sensitivity, which most people would prescribe some type of neuroglides or flossing for, which actually isn't maybe appropriate because you don't need to improve the neurodynamics of the nervous system if they're sensitive to stretching. So if you're prescribing flossing or glides, you really should be differentiating between an adhesion where the nerve is stuck and actually not gliding the way that it should be versus them getting pain when there's stretch put on it, right? You wouldn't go prescribing somebody that just sprained their ankle to go stretching their ankle because they're sensitive to that stretch right now. You would probably create an environment, hopefully, within the body that's conducive to healing to allow the healing to actually take place, the desensitization to occur, and then deal with those impairments later on. And then static position here is, the classic, I've got a crack in my back, or they have to be constantly shifting around because if they stay in one position for too long, it hurts. Now, if these things were in silos like this, it would be much easier to understand and to apply, but it's just like life isn't a textbook, right? You can be position sensitive only when you're under load, right? You can be neural tension sensitive only in certain positions. You can be neural tension sensitive only in certain positions and only when you're under load. Or you can have a little bit of them all, and when they all get combined, that is significantly worse for that patient. And you have to be able to parse out which one of these is more important. Is it 50% load? Is it 80% load? Is it 80% neural tension? Which one is going to have the biggest impact on that patient? And then static position intolerance over here, sensitivity, is not in its own silo either. You can have all of these overlapping that static position intolerance. And if that's the case, we have to deal with these first before we go dealing with this over here. Because if you don't, they're still going to be irritating things, right? Imagine this. If I fall asleep hugging a pillow every night, my wrist is probably going to hurt, right? Do you think it matters what exercises or stretches I do if I don't stop doing this to myself all the time? No, it's not going to help. I'm going to stay in pain. And that's exactly what happens here, right? People go prescribing exercises that are inappropriate because they don't understand this. So if you don't understand this, how are you going to prescribe exercises that aren't pissing the patient off, right? And then if you're having patients that are getting better without having this understanding, chances are they're probably just going to get better regardless, because they don't have education, they don't have the information to stop jacking themselves up all day. Humans are incredibly resilient. They tend to get better, right? Which puts luck on the clinician's side a lot of the times. But when people are getting 75% better, 80% better, or they have this recurrent pain that you can't figure out, it probably comes down to a lot of this stuff, right? Think of this. Think of a stenotic patient that they can't sit upright. They have to bend forward, right? But they can't lay flat on their back. Well, it cannot be the loading, because when they bend forward, that increases the loading, and when they're laying on their back, they're only at 25% of their body weight on their spine. That has to be a positional sensitivity. And you can think of a runner, right? Think of someone that has pain with sitting, but they can go run. Well, we know sitting increases the loading a whole lot, but so does running, right? So that can't be a load sensitivity. That, again, has to be a position sensitivity. We have to be able to parse these things out and think through them quickly and logically, and then make it make sense to the client.
So when we're talking about load, and Roger gave some examples about spitting out your toothpaste or sitting in a chair, it's not that these positions are inherently dangerous. Like, take loading and hinging, for instance. Flexing the spine is not harmful. We need that range of motion. But when somebody's load sensitivity, or when somebody's load sensitive with symptoms, we need to educate them and modify some things to just say maybe not right now, because those are the things that aren't creating the environment that are going to get you better. And so going back to the original context of me saying, oh, it's the 10,000th bend forward that you did and picking up the pillow is what threw your back out. It's not just the movement pattern 10,000 times that caused it. It's this accumulation of all these sensitivities that Roger was talking about.
Yeah, so the big thing with this spine that most people don't understand is that it acts more like a credit card, right? You don't get pain immediately a lot of the times. There's this delayed effect. You can go swipe your credit card for 20, 30, 40 bucks a whole bunch of times, and it even feels good in the moment, right? People are in a bad mood. I don't know, they just went through a breakup, they go and do some retail therapy, and they feel pretty good in the moment until they get the bill in the mail later on. Right? And then it's painful. That's why a lot of times people are like, oh, sometimes I can do a lot and I have no pain. And other times, like, I'm doing nothing, even though when they're doing nothing, they're existing in a position with forces on their body. Right? I'm doing nothing and I have a lot of pain. It doesn't make any sense. That's because they don't understand the mechanical stressors, and the clinician probably doesn't understand the mechanical stressors, and then they don't understand the delayed effect. And a lot of times they're doing things in the moment that feel good, right? But you know what else feels good in the moment? Smoking crack. People that smoke crack, they do it because they like the way it makes them feel. It makes them feel good. What happens when you keep smoking crack, though?
Fuck your life up.
Stay in pain long term.
So knowing all of this, if you know that somebody has a certain sensitivity, it becomes helpful if you know the mechanical stressors and you know the neurovital signs. You can prescribe the plan confidently. So somebody can have no pain, but if they have the neurovital signs that tell us that there's something going on and that they have a sensitivity, we need to create a plan of care accordingly. So then it becomes about the education, the patients, and the appropriate progressions based on what we've found in the exam with the mechanical stressors. So how do we then actually diagnose for the mechanical stressors? How do we find those out? Well, the precursor is first understanding what the hell those are, right? Like, if this confuses you to this point, you need to get a better understanding of mechanical stressors. And once you have that, you have the diagnosis and testing through your assessment. Things like range of motion, a slump test, straight leg raise, neurovital signs, and then being able to put it all together into something that you can make sense of.
Even before that, like, you should be able to start picking these up from just the subjective examination, like the things that people are telling you, the patterns of their behavior. So you should have a solid hypothesis before you even get into testing.
Yeah, expert pattern recognition.
Yeah.
Shortcuts the process a lot. It's not magic, right? Like, there's no one magical test that makes it all make sense. Understanding mechanical stressors and being able to take all of this information and compile the data into something that makes sense and gives you the information on the mechanical stressors is the magic piece, is the thing that puts it all together that makes you say, wow, I know what's going on now and I can make it make sense to my patients. Because if you can't pull data from your evaluation and extrapolate the information that you need, your clinical reasoning skills are the problem. Like, how do you use a straight leg raise to differentiate between neural tension sensitivity and neural tension sensitivity under load? What about differentiating just between flexion sensitivity and load sensitivity? Like Roger said, there's the overlap between all of those different pillars that happens, and you have to know how to test that, because that brings in the plan of care that you're making for your patient and the advice that you're giving them. So where PTs typically fall short is here, and it's in putting all this information together and making sense of it. Because if you don't make sense of it, it completely inhibits your ability to make sense of it to your patient.
If you're treating your spine patients specifically based off of their pain, you're entirely missing the boat. That's why so many people have bad backs and bad necks with recurrent pain, because they go somewhere and they treat them until they're out of pain, but they're not monitoring the neurological vital signs to make sure that the nervous system is actually recovered. Because the absence of pain does not indicate health of the nervous system. You have to be monitoring the neurological vital signs. If all this is new to you guys, if you learned something, if you want to find out more, find me on Instagram @DocRaj and shoot me a DM and let's chat about it to help clear this up for you.
We'll see you on the next episode. Don't forget to subscribe.